Thank you, Dr. Onjai, for the wonderful remarks. I'm glad to be here. It's always good to be back home. It's amazing that sometimes things happen. Look at what happened today. This is serendipity, which means, sometimes bad things happen and you think they are bad. It turned out to be actually good. We were going to have somebody who will talk about evolution first. That person, as you've just been told, is no longer available, at least not for the moment. So while we try to connect, listen to the presentations we had that morning, as if they substituted for him, to the point that they've now created the basis for me from which or on which to build some of the things that we want to talk about today. We chose this topic for obvious reasons. Sometimes while other people are going to the sky, some countries are still fighting to get to the village. Okay? This is a fact. And when you look at health systems around the world, while we have achieved a lot here as a country and other countries like us, we still have a reason to go back to the basics. Some of those things that while other people are dealing with epidemics and endemic situations of chronic illnesses, we have our own share, don't get me wrong, but we are still struggling largely with infectious diseases. So we thought, well, let us re-examine our own situation first and see who we are training and how we are training them and what prospects and possibilities are available for us to determine our next trajectory. So who will help me change the slides? You? Okay, all right. So let's go next. So with the time given to me, I intend to run through this quickly. Remember, I have 45 minutes to do this. And the goal is not to do a real deep dive because we have eminent people here in this room. Forget about the titles. Some people have been doing this before some of us even came of age. So we have to tap from those resources, just like I said. So we'll talk about this as you can see the outlines there. Next slide, Mohamed. For an icebreaker, I want each of you to think of one word that represents your hopes for the future of public health training in Sierra Leone. It could be anything except funding. You know why? I'm tired of hearing funding. Because it seems as if that's the substitute, that's the panacea, as if we had the money, then everything will be fine. I don't think so. Don't get me wrong, it's important. So I don't want funding. Let's think about other things. Please share your choice and why. The chair said we will have time to reminisce and talk about this. So just think about that. Next one. Another one, imagine you are tasked with designing a new public health training program, but you can only use 3 words to describe its core mission. Take a moment, think about those 3 words, and write them down. If you have a pen, I think we'll give you pens. We can revisit this during our panel discussion. Okay? The chairman will take care of that. But let's get to what I want to talk about right now. Let us set the stage. Because I understand that sometimes those of us who are in the business of doing public health may not have degrees in public health at all. Okay? That's not a problem. Public health is very multidisciplinary. Okay? If you have an outbreak of infectious diseases here, go back to the history of the discipline itself. John Snow. We have an outbreak of cholera and somebody is saying, well, what's the problem? Well, the statistician can tally the numbers. You probably need the engineer to come and fix the tap itself. Okay? So that is why this field is very multidisciplinary. The MPH and other disciplines are all part of it. But if you get to the business of defining, then a public health person is one who is educated in public health or a related discipline employed to improve health through a population focus. I need to make this very clear, and I know we know this. Sometimes the analogy we use is that public health is an upstream approach. And the chair just said that. Medicine is a downstream approach. What do we mean by that? In public health, the patient is the community. In medicine, the patient is the patient. A lot of times we deal with individuals one at a time. That is why it's like, think about this in your head or in your mind's eye and see the doctors, not that they wait, but by discipline, they fix problems. So people get sick, we rush them to the hospitals, they look at them, and they diagnose what the problem is. The public health people say, we don't even want that to happen. Let us use all the levels, and it is only when we miss things, and we sometimes do, because of many factors, people's genetics, people's behavioral lifestyles, and so on and so forth. So things can slip through the cracks. And when they do slip through the cracks, then we get to the doctor. So it is important to emphasize this, and Dr. Njai said that. While the two disciplines are inextricably linked, they are also distinct in their own rights. Okay? So that's public health. Next. We know this. I know many of us know that. But, just to, again, start from the beginning. These are the traditional, and that's the operative term. Traditional meaning when things started. Epidemiology, the study of the cause and distribution of diseases. Social and behavioral sciences. Why is it that in spite of what we know now, in the United States, for example, 1964, the Surgeon General said for the first time that we now have irrefutable evidence that there is a relationship between smoking and lung cancer. Can't deny that anymore. So that became a milestone. So we've known this for a very long time, and I'm not suggesting that they are the first people to establish that. But in spite of all of this, too much food is not good for us. Some of we, they still eat boku. And a long time ago, the emphasis was on how much you eat. Now that emphasis is changing. It's when you eat what you eat. Some of we, they eat fufu and then you go to bed right there. And you're still sitting there, no exercise at all. That's the time when you need additional metabolism. So behavioral science is about why do people still do those things that are injurious to their health? We get all these models, stages of change. Many of you know this, you've studied them. That's what that is. Public health biology. See the relationship, how closer we get to medicine, how all of those genetic factors are integral parts of public health. Health policy. This is very important because it takes a number of facets. Sometimes when we talk about policies, most researchers will tell you, you have three things to confluence, to come together before you have a policy. There has to be a problem. Yeah? There has to be a solution to the problem. And there has to be the political will to do something about that. It's when you have the three things together that the likelihood of a policy output becomes real. So that's what we talk about. And that's very important because the impact of policy, if you talk about the ecological framework, which many of us know, the levels that, or factors that impact health, policy is perhaps the most critical. Because, thank you so much. Because the one policy change that the minister was telling us about things that the government can or cannot do. We'll get to that a little bit later. Environmental health, this is everything. This morning we had rain, lasted for about 30 minutes, yes? And I was driving through the streets coming here, and I was telling the driver, look at how much dirt, how much trash we have on the streets. Let's go back to the basics. This is not about groundbreaking research. Let's clean the environment first. Okay? And then you have, what's up there? Biostatistics. Many people don't like biostatistics. They don't like numbers. I used to not like them when I was an undergraduate student myself. But you have to make sense of the numbers. You have to make sense of what has happened and how can you learn from that to project your future. So that's what, you talk about designs and all of that stuff. Sometimes we need to go back in time and conduct trend analysis and see what we've done well, what we haven't done so well, and so on and so forth. Where do we go from here? That's what that discipline is about. So this is the core. But then you have some sort of cross-cutting areas. A public health policy has to communicate. I'll get to some of those things. Next slide. Trying to use my 45 minutes wisely. These are some of the skills that we need to have. Analytical assessment skills. You can't hit numbers. Public health is not a storytelling discipline. Okay, it's like lawyers say, habeas corpus, show me the body. Where is the evidence? If you are going to go to the president and say, I want 10 million leones to go do project A, B, C, D, okay, why? Why should we give you the money? There has to be the numbers, the data to say this is, in fact, makes sense. So the evidence is very important. Communication skills. Sometimes people talk at the ivory tower mentality. And we waiting at the universities are very fond of this. Sometimes you go to communities, you think, oh, I know so much. You know, the community are empty receptacles. We just pour in everything, and we are going to unload or unburden our mind. Nothing can be further from the truth. Okay, that's very important. So, but then, how do you break down that information? Mohamed will tell you, a recent student of a graduate program, you know, when you get all these disciplines and somebody says, oh, we're talking about statistics, and when we do the analysis, this is statistically significant, P less than point. What are you talking about? If you go out there in the community and you are trying to explain a serious problem, and you're talking this high-sounding concept and philosophy, people are not going to understand them. You're able to write them when that becomes necessary, but you have to have the ability to explain it when that is needed. Okay, cultural competency skill. I have a graduate degree in anthropology. My colleague here. Nothing is more important than our cultural values. When I came 2014, and you know, we work in the, I forget what it's called, the hub. You know, Dr. Jambe, I will tell you that. One thing that I noticed was we had all these experts from around the world. They came, they were telling us about how we should deal with Ebola and all of that. And although my later background is public health, but I had to go back to anthropology and say, where's the cultural sensitivity here? I was touched by that. I didn't finish. I came for 7 months. I think I did 6. I went back. You know the first thing I did? I have to write a book about this. Somebody has to understand the way we think now, we own culture. So the next time when you come to talk to us, so I called 2 other anthropologists and said, let's do this. We'll publish a book. What's the title, if I can remember that? Cultural Sensitivity in Health Services. And then we took the 3 countries as case study analysis. Because remember, some of you, all of us here are old enough to know when people then kind of begin say, well, Muslim people are not for what's the body them. Yeah? Okay, before we fully understood that this can be done in a culturally sensitive way. So what did happen? People then they hide the body, then still they go outside. And then we had a problem. So you will be better off trying to know, okay, we'll therefore do this, but in a way that is culturally sensitive, but also health promoting. And then come this whole thing now and go put the body under and then map now, what are they doing, Duawe and all of that. That's what we're talking about. Community dimensions. The speaker this morning said that the community is the patient. You can't ignore them in this process. Okay? Financial planning and management skills, leadership style, systems thinking. I talked about this in the other seminar the other day. Leaders are different. Sometimes it's the situation that defines who you are. If you come in with this attitude, okay, I tell people, wisdom does not sit at the top. Just because you're not the boss, no means you know everything. Sometimes it comes from the bottom. But you have to be very willing to listen. In the end, you take responsibility. So there are different leadership styles. Please. Okay? So but why is this topic important for us today in Sierra Leone? Because we need to understand the current state of public health training in Sierra Leone. Whether we are talking about formal academic training or informal in-service training. I'll get to that a little bit more. The next one is current experts will retire. We know that. Then therefore go. It's a part of life. When these people go, we have to replace them. In the United States, for example, they need the latest that I saw. They will need to produce 4 more graduates to replace one person who leave. I mean, to get the you know what I'm talking about. To replace just those who are retiring. So think about that. They have so many, can't even catch up these days how many schools of public health. I'm not talking programs, I'm talking schools. So how much more? How many do we have in this country? I'll talk about that and see our trajectory. Imagine infections and professionals have to retool. You were trained in X, Y, Z some time ago. The world is changing. The bacteria are recreating themselves. The doctor will tell you that. So if you want to stay relevant, you have to do things, you have to catch up. AI is there now. You will be shocked if I tell you what AI can do. You won't believe you are in this world. Okay? The importance of addressing challenges for future improvements and clinical training goes hand in glove. Again, I want to make sure that I'm clear about this. I'm not saying public health people and health clinical clinicians can't work together. The departments the school that I head has 7 clinical programs and 1 public health program. So we work with them all the time. Next. So I want to talk about health indicators from another perspective. Sometimes we get bogged down with the numbers. 29 people are dying out of everything. I want to stay away from that. People forget numbers very easily. But let us look at some of the things that lead to the numbers. Yeah? Life expectancy. In our salon today, I don't even know the life expectancy in our salon, to be very honest with you. I know that in the United States, you're talking about late 70s, 80s. We here, if you live till you're not 60, you're lucky. Because we have the silent killers, people die, you come one time in December, the next time you want to, say that person don't die. So life expectancy. Yes, we've made some gains, but nobody in this room can deny that we have a mighty long way to go. You go and look at the numbers. Health expenditure, I think when I looked at the data, something around 4 billion something. That's pittance. That's pittance. And I'm not blaming anybody here. I'm just saying the money is small. We need more money than that. Healthcare is expensive. That's a fact of life. Okay? Maternal child health, mortality rates, disease prevalence, and incidence. We have some diseases that we can manage better now. Prevalence rates may be stagnated, maybe they are going up. The new cases that we call incidence rates are there. How do we address them? In which areas have we made a lot of progress and where we are either stagnated or actually retrogressing? Look at this. When you look at historical events around this happened, a long time ago I published a paper about the Ebola situation in Sierra Leone. And guess what? One of the findings then was the patient-physician ratio. Patient-physician ratio. Now, Liberia and Sierra Leone, seriously, you know most? 2 doctors have to see 100,000 patients. 2 doctors. And I know this is an unfair comparison. But when I look at, okay, let me ask you, who side in there? America, 2 doctors for 245 people, the patient, workload. So when the nurse comes to work and in face twists and all of that stuff, the matron, no one for smile, you know what's happening. I know they go to the doctor self. We talk about staff burnout. I mean, who can address that number of people? So instead of, going down and looking at the numbers, but before we even got to the Ebola outbreak, our systems were already compromised by the war. The health system was fragmented, in some places completely broken. In spite of all that, and I'm humbled, and I doff my hat to you guys in this room who do this work, because I always have a moment when I think of my country. My secretary, every now and then, Miss Cosby will come to me and say, now remember, this is my office, and there is a room as big as my office itself, full of supplies. Anything we want you to get, Andy. And at the beginning of every semester, she comes to me, Dr. Kanu, is there anything that you want me to order? I think about Sierra Leone. Okay, here I am. Look at what is there to be used. Think about the professors. Think about the nurses. Think about what they have to work with. But you guys are heroes and heroines given what you do. And we owe you a lot to do this. But these are some of the realities, Mohamed, let's go. These are some of the realities of, so having looked at the landscape, let us quickly look at the current training landscape. Existing institutions, local public health training institutions, JALA, UNIMAC, I hope that spelling is correct, other public-private institutions. Many of them have just recently developed public health programs. I don't know how many programs we have. I know that Commerce and a few other people have, a few other institutions have these programs. But we need more of those. The question is, do we have the resources? Because sometimes you just don't multiply programs. You have to have the resources to do so. Other issues that we have to really focus on, and the doctor talked about this, core subjects and skills that are taught. Public health has an expanding culture. It's not static. You know, a few years back you go, what was the talk? Avian flu. Yes, you remember? Bird flu. We fed to them, get a hold of them. We did well. The world did well. I think we lost about 700 people. Compared to other outbreaks, could be worse. And then as we thought that was coming to an end, Ebola came. Kill who he had to kill. And then we thought we are making a headway. COVID came. Who knows what is going to come next? So if you have an expanding agenda, the core subject areas and skills that you are teaching have to be reminiscent of that fact. How much specialization do we have? The competencies in traditional core areas, we talked about this. So we have to go beyond. I was interviewing a PhD student or applicant from India 2 days before I left. And his interest is to look at how AI is influencing public health. Nothing to do with the traditional areas. So if you are stuck in your own area and you are not expanding, the world is moving and you are lagging behind. The application and at what level? We have to look at what we train our students. You know, when we do, what is it called? And I'll talk more about this later on. When you train somebody, I tell people, this is not my own story. The two happiest moments in this teaching business where they pay is this. Of course, they tell me they pay me, right? When I give a good check, that's a very happy moment. So that's one time. But the other good time is when every now and then, one time, for example, I had a student who became so fond of me. And one day I sat in the office and my phone rang, my cell phone. And who wanted to talk to me? I can't even remember the young lady's name. And she said, "It's me. You remember? I told you when I crossed the line and get my PhD, and I'm going to let mommy talk to you. Now I have made it." The point is, anytime you train somebody and that person becomes successful, if you are proud of what you do, of course. But the point I'm saying here is, we have to go beyond the nomenclature, just the name and all of that stuff. The question we have to ask ourselves more is, how prepared are the people that we train? See, we in the US, when you train somebody, when you want to go for accreditation, they ask you the question, you have to provide evidence. In the past 3 or 5 years, how many of your graduates have been employed? If you teach somebody get a degree, go, nobody know one for hire them, you have to ask yourself, did you train them well? Last semester, I brought my nephew to the US to do his master's. I don't know if I should say fortunately or unfortunately for him, he had to take my class in the very first semester. And, I don't know if you think it's going to be business as usual, I'm uncool and all that kind of stuff. And after the first lecture, he said, "Hey, Uncle me this thing, huh?" Now I say, "Just go and wait." And sometimes I call my boy, and if they answer like saying, "I die, they can't die." I say, "Oh man, it will be okay." It will, because some of those concepts he talked about, and now they give you real data. If we're talking about statistics, they give you actual data. Go code and recode a variable for me and tell me what these numbers mean. Not tell me about P by source this and all of that stuff. If you use these numbers for explain the number of Pekin where they die in a PCMH, what did this mean? How would you explain this to the minister, anybody who has to make policy? That is application. Let's move away from theoretical concepts, stages of change and all of that. What did that one day mean? That's why in my classes, I tell students, you make those statements, I heard you. Go do one balak and see if you really understand what I'm talking about. Let's go. So for me, this is my thinking, and please correct me, I'm here to learn from you. I think if you follow the recent trajectory of Sierra Leone in the public health landscape, I think this is kind of our rough trajectory. Thank God we have Dr. Jamba and several other people like you. I think for years, I'm talking about specialized academic-based training, institution-based, it's been relatively limited. Growing up as a young guy, I used to hear about paramedical NABO, School of Hygiene, and so on and so forth. That was about it. I'm talking public health focused, institutional-based training. Okay? And then for years, who were there, I know they say other one audio, but these were the ones that were very well known. We moved from there, I think, in the past few years, we have the development of MPH programs. It's a recent phenomenon, you know that? Okay, we have Jala, McKinney. I'm yet to know about doctoral programs. I don't think they exist yet. Okay? But we've made some progress. And then when we move from there, we go to training public health. Clinical medicine is sometimes infused together. What we are doing here is we are taking a lot of our clinicians as if the work they have is not already too much for them and asking them to teach many of the public health courses. When I came in 2014, my nephew was doing his dissertation thing. I said, let me see what you're writing about. And I looked at the profile of the people who are teaching. A lot of them, the majority of them are MDs or medical doctors. That's a fact. That's MDO, I don't know for now. Okay? So let's be clear here. Doctors need public health training, no doubt. Public health, the bedrock discipline is statistics and epidemiology. Okay, that's where you get the skills for making you able to read a clinical trial upon which you can draw to make a decision as how to treat your patient. That's what we call evidence-based medicine. Okay? Medical curriculum, then get so much to study. They don't have time to go sit down, they read one concept of statistics after another or epidemiology. No. That's why if you look at the way it's going, we'll get the Dr. Jambais of the world who were trained a few years back. Some of them who are still working, they come back and get the MPH. Because now they get for lead programs, they have to direct programs, they need that leadership component. But they also have to do evidence-based medicine. The younger ones, most of them, they start with an MPH. First of all, when they do that, it makes them more competitively buoyant to get into medical school. So they are crisscrossing. The lesson is both are relevant, but they are distinct in their own right. That's what we have to understand. So, but that's what we are doing. So again, related, but also different. And then I think where we are now, and I think maybe for now I can say that is the zenith of success. The establishment of the National Public Health Agency. I was looking at some of the things they've been able to achieve. Kudos to them. Problem is, from my interpretation, a lot of the funding is coming from elsewhere. You know, sometimes they say the more things change, the more they stay the same. I wrote a book chapter, I think, when we see at this, 2002, thereabout. And I actually interviewed medical doctors. I surveyed medical doctors in this country. I think I had 47 respondents without question. In fact, they actually think without external funding, they don't know what will happen to our health system. So what I'm saying to you is that even when the National Public Health Agency is doing well, you know, it's still in its embryonic stages, of course, but is the funding going to be sustainable so that they can continue to break new frontiers? Let's go, please. So, some challenges. Concentrations must match expanding threats. That's what I'm saying. We can't continue to take a very narrow focus of the traditional core areas and ignore some of the things that are happening. A few years ago, global warming was not a very big thing. We own President Alap. I mean, he doesn't even believe in global warming. In what world are you living? Honestly, I mean, you see all these signs. Look at Sierra Leone now, we get heavy downpour in March. Yes? Not what I didn't teach me in primary school. March now been dry season. In fact, it's the peak of the dry season. You know? So you have to try to train people. But let us talk about The quality of education. Standardized entry requirements across institutions. Honestly, this is not just public health. Sometimes when I come here and I look at institutions, even some of my own nieces and nephews, when I look at some of the requirements they have and they are accepted at some institution, it's not like an rat race for money. It's a competition about who gets the most students. And what people fail to realize, that person the way you push for go through a certain level, now you ever be your nurse tomorrow. You could die. Or somebody related to you will die. You know? So these are the things. So entry requirements are very critical for us to have. Field experience, insufficient practical training. For 9 years when I was the director of graduate programs, before I left that position, I was the preceptor, not preceptor. I worked directly with the preceptors. Who side would they send we master students them? You know, PhD students don't do that. But for the hours where they do, we evaluate their performance. In fact, the component that I teach constitutes only 40%. The 60% is what the preceptor they say about you. You know, before I left, one student who was doing a capstone project, interestingly, he took the course with me, and you know, finished what he's supposed to do when somebody else took it over. Now he's applying into the PhD program, and we rejected him on that grounds because he has not done the presentation for the capstone. So this is serious business. People for comment and no say, by the time they walk out of the gate, how much do you know? How many of those concepts that were given to you that you can really apply? Because when clinicians, when health professionals make a mistake, we lose people. And that's the difference. Let's go. All right, so funding limitation, we already talked about that. The shortage of trained and experienced public health experts, the proverbial brain drain. Some are retiring. Some just they get fed up. You know, poor compensation, you know, people get for feed families. You know, there are people who arguably still make 2 million Leones a salary or 2,000, whatever it's called now. Who can survive on that kind of money today without having to do something that you may not be proud of? We all have to contextualize it. You can criticize people from now to Jericho, but sometimes you also have to look at their reality. Okay? Our accreditation requirements and workforce demands, that's very important. I mentioned that today. Somebody sent me some documents, somebody will get institution, and wanted me to look at it and make recommendation. I had to smile. And I want to help my country, and I don't want to sound disrespectful. But when I look at the standards of waiting the need for fulfill no more before they grant accreditation, I just said, we need a lot more here. I tell you my own personal story. Somebody from one other college, they want somebody for teach an epidemiology course. And they reach out to me and say, Prof, do you have time, you know, out of your... And I said, let's see, maybe I can try. And I said, yes, I'll do that. Then go, then put it in, they were going to pay me extra for that. And then send them to the curriculum office. You know what they say? They say they're not they allow me for teach that course there until then say I get 18 hours of training in epidemiology. This is a guy with a PhD in public health. I turned 20 years being a professor this year. My master's and PhD are all in public health. But they're not going to take me word for it. Sorry, we're not want for be disrespectful. We just want the evidence. In fact, they not talk to me, say, then just tell the person, if you are we are not paying. And then tell me that. They felt embarrassed. They thought I wasn't that prepared. Eventually, they sent me this. That's okay, fine. Here is the transcript. Let them go do the assessment. You know, and the rest is history. But that's what I'm talking about, the rigor. When we get the things that when they ask we for approved programs, forget about the academics first. Left that one day. That one in a later pieces. Do you have the structure? Are you going to put this number of people in a room like this, you say they can't do program? Learning has to take place in a conducive environment. You get for tell me first, what are the financial resources where your institution get? Because where people that don't count, they enroll in at your institution, and 3 years later you can't pay them, you don't mess up with people picking a career. And. So this is an area that we really have to look. And I know we want to get more institutions. That's good, so we can train more people. But remember, we are training our own professionals. So this is very serious business. And what I have to say is this. Existing public health programs cannot be everything. Almost economics people, they will get now, yes? I don't trust my economic studies. That's why before they can't talk now, they say can't learn point. When I was in 4, I learned a concept in economics that they call the law of comparative cost advantage. Allow people to do the things that they can do when they spend the less. Something will come naturally with the person. If you are a businessman, why do you want to do something for which you're going to spend so much money? Focus on the one where you will get the most output. It's efficiency. What I'm saying here is, let us don't have programs. We won't forget all concentrations. And you only have 2 persons who get maybe a master's in public health or 3. Well, where the other area they're done. That's when you start to put square pegs in round hole, just for let make no more. That's the point that I'm making. So we have to pay attention to that. But there are opportunities, in spite of all of these problems that we've talked about. Government initiatives, policy supporting health workforce development. Provide compensation, extra compensation for people who provide services, for example, in rural settings. America safely do them. Many of them doctors, the way they come in other countries, where then they go to America, now they side they will side the typical weight man, Pekin where they're born and that trainer, they know one for go there. We own brothers then they go. And I'm not just talking about Africans. I'm talking about, professionals from, Southeast Asia and other places like that. Then they did it. If we want to send somebody now the riverine communities, for example, for some time, let there be some additional compensation compared to that person way in one for day now the citadel of power now. Okay? Let us make mandatory continuing education. I mean, it's very serious business. In our department, in the dean's office, every semester I sign like 2 or 3 papers for the professors having to renew their licenses for continuous training. Yes, you're an MD. Yes, you have your PhD. We get that. We know that. We believe you. We are just saying you have to retool every now and then, stay with changing times. We can't say, oh, if you want to do another business. If that's the attitude, I mean, for Lambo, not too easy thing. Now they beat them picking there with the waiting call. It's useful, but nobody wants to study a lot of times if they can go around it. It's the path of least resistance. I mean, a human nature that one day. If I can get something, get along with a more easier situation, and say, where do they go? Yes? Technology integration. Oh, did I jump one there? International partnership. Collaborations with global health organizations. This is very important. This organization, as young as it is, last year? No, year before last. We competed with funding with Bill Gates Foundation. And we wrote a grant. I'm sure my boss there will not want me to disclose you know what I'm talking about. So we did the study. Look at family planning and uptake and all of that stuff. We are publishing 6 papers out of that study. 2 are currently being reviewed. We are about finishing the other drafts and so on and so forth. That is what I'm talking about. So reach out to other organizations, make yourself competitively attractive. Technology integration, e-learning platforms, and telehealth. Now you can see your doctor, you sit on the doctor in an office and they sound you and write prescription for you. Now that sounds like some fiction, but yes, it's happening. Okay, but if we can't get there yet, but at least we can increase the number of training programs that we can do online, virtual. A few years ago, in the summer, I was teaching 2 classes conveniently from my house. Conveniently. So we have to explore those things. Interprofessional training and collaboration. Again, these are some of the things. In all institutions in the United States, interprofessional collaboration, not by force. You don't get options, sir. You have to be able to take a nurse, an OT specialist, a PT person, a cardiorespiratory professional, a dental hygienist, and the doctor, and say, okay, this patient, what if you get all the problems the way these people live? And you are now having to work with all them people here. How do you manage how do you meander your way through all that? And it's required. So, in fact, this is something the dean's office, only the dean and myself do that. We actually lead the training. In fact, we've published a paper out of that. So these are the type of things that we're talking about. So sometimes training doesn't have to be formal. Sometimes it has to be informal or in service, if you will. I think there we have to set the tone. Sometimes you get people who no one for do the work. Here are some of the actions you can take. Do not tolerate mediocrity. That's where you start. Okay? If you get past that, reward those who can do and will do. There are some people, then they do the work. They want to do it and they will do it. All right? There are some people, train those who can't do but will do. Then they really want to do it. Then just no one's, they don't get the skills they need. Train them. Help them to get the training that they need. Reprimand those who can do but will not do. Either because of their connections, they think, I can get away. Show them the exit. Let them go out. And then terminate those who can't do and will not do. I don't know if you get that power day, but that's what needs to happen. Some time back, when I was again in that other office, I had, this mommy, what's her name? That mommy all take an excuse. She comes to work. If it is not the coffee spill on the dress, so she's 30, 40 minutes late, I try to be patient sometime. If he drafts a document and send it to me and wants me to edit, I can end up the red ideboku past the black ink. Then I can say, what if I just write them? I probably will spend less time. You can't run an office like that. And I'm sorry, after some time, I accumulated the evidence, I made a recommendation, and she had to go. For the good of other people. For the good of other people, it's not me. I can go and work without her. But you are here to expedite the work that we do. If you can't contribute meaningfully, sorry, but we have to let you go. Government initiative, I think we talked about this, policy supporting these collaborations with health. Yes, let's go to the next one. I'm sorry. So recommendations, improve technology. This is an existential threat these days. You can't really do much these days without technological improvement. I'm sorry, it's just a fact. You go to some offices still, you see the computers, you can't even tell what type of software or what's the most recent software there. Seriously. Identify robust and enhance online offerings. There's a mixed match. Be careful about online programs. That's the only caveat why they say. If things are too good to be true, they may not be true. And if you pay so much money, please don't focus too much on credentials. Focus on the knowledge gain. That is what makes you a professional. That's why nobody will feature you in one office. You know why? Because you can leave. And if you leave, you can be employed elsewhere. If you tie your fortunes to a single organization, they don't get you. Now there you go, so you don't retire. And they can give you whatever type of treatment. Strong health sector collaboration with academic institutions. This is very important. Okay? Sometimes when you do these relationships, you can tell the institutions, this is the area we want you to develop a course to help our people. Don't come and give us generic training. Now this we want. We want the people that we want for do bill management or something like that. Whatever the area. This is where you have to collaborate. Emphasize rigor and develop tailored programs. Have honest discussions about leadership transition. And this is also very critical. We get leaders where they think they are going to be there forever. No, you get for go. Like it or not, you get for go. If they not fire you, if they not terminate you, you go old, Dr. Jai go get tired and say, I want to do something different. And please open up to your subordinate. things happen. Something will happen to you. Last year, the chief of staff at my university, very hardworking man, 63-year-old, Dr. Johnson, he comes to work around 5:30, 6 o'clock in the morning. He's the last person to leave. Saturday, the university get a game. Everybody was hyped up. Then go there with the president. Came home. He lived by himself, by the way. Monday morning, they not see him. And they know this is quite unlike him. They send somebody for go check nine house. Pastor and broke the door. He's a dead man. Guess what happened? Within 24 hours, Dr. Phillips was announced as his replacement. So while you work hard, don't forget yourself. Nobody is indispensable. If you die, we will bury you, and then the war will continue. So in closing, additional recommendations: explore, initiate, provide, enhance scholarships and support. I know these are very difficult to come by, but keep trying. If you can't identify something from within the country, maybe if you have people who have the expertise, the diligence, you never know. Sometimes some opportunity might come. Rethink academic in-service training structures, semester calendars, study leave options, curricula and course format. Some people stifle other professionals' development by having rigid, inflexible conditions. Somebody get opportunity for go study leave, that one I'm not going to sign now. I sit down now, I go tell seminar the boss. You're not just punishing one person, you are punishing the country. Sometimes this person I get the IQ, the love, the determination to do what it is that they need to do. Revisit institution barriers. Okay, I think I just talked about that. Revisit institution barriers to progress and completion. Civil service requirements. We made the policies. Who says we can't change them? Now, so the policies. Okay, now policy now writes the policy. Let's change them. Avoid early over-specialization into narrow tracks. Keep options open. And this is for you, Dr. Njai, and your people, or our people. We are guilty of this sometimes. I mean, I graduate from an English-oriented thing. I tell me, Baba, we reach. Now I say, Mister, you they fail now the course the first 3 weeks of the semester. You don't fail them. I think you know you understand what I talk. Until the mid-semester last, and you don't do 1, 2, 3, 4 assessment, and 50% of the grade is already accounted for. So that 50%, well, like you get 50%, you don't fail them. The British system of education, don't get me wrong, is good, especially at the undergraduate. But it's very heavily exam leaning. You know, I remember how they from the college, you go and make crusade. When they say, would they call them, how would they call them, fixtures? Down at the timetable. When they say fixtures don't come out, the woman don't serious. If they go from the college, they pass, like I say, people, they know they do. If you study like that in America and other places, you will fail. Because the first lecture, sometimes the next class, you get assignment for take. That is what 10% of your grade. Yesterday, I got an email from a student. The missed assignment one was 15%. I think all of a sudden he realized it, in spite of what you don't do, you're not going to pass this year. She sent me an email, and I said, you remember we had this conversation? This is what I knew would happen. Now you are where you are because you wanted to be there. And I know they change my rules in circumstances like that. So, short-term, pilot programs and partnerships. Borrow expertise from abroad for short-term accelerated. Me, if I be some positions there, if I hold them at this country. There's a wealth of experience out there. People then they really will for come. We're born here, I know talk about Whitman. Many of these people are professionals, consummate professionals in their own right. If you really organize them and say, a course that should otherwise take 3 months, una can't deliver them inside 2 weeks. You know, accelerated programs. We do that all the time. This Saturday now they do graduation. 1 week after that, we get what you call Maymester. Would they do the work of what is equivalent to 1 semester in 2 weeks? The students will get the aptitude for that. Some students are talented. Then they do it. Then they pass and they do well. So do those kinds of things If them people, and some of these people are willing to come and do this pro bono. The professor just tell me, he get for make, let me teach one course. And I promise you I'm willing to do that. Okay, that's what we're talking about. Focus on applied training rather than theoretical concept mastery only. You guys talk blah, 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 then give you paper and say, well, do an hour. You sabi talk how, but you no sabi do. Let us do the apprenticeship form of learning. Now, so for teach. Teach the student, do one for them, and make like do one. Let you see. Develop interprofessionalism through content-related cases. Integration of more, what's that? Formative assessment. Don't wait until the end. Process formative. Now, when you develop a program in the early stages, this is when you assess. See what's going wrong, then you get an opportunity to improve what is not working. Don't wait until the end. It may be too late to do that. Establish and or strengthen accreditation standards. I cannot express this enough. Some of the schools they allow for existence alone, they really should not exist. They're not for exist. We are doing a disservice to our children. You know, we are doing a disservice. All right, this is the last slide. Bear with me. In terms of long-term, sustainable health workforce development. We talked about that already, yes? Provide incentives and so on and so on. Improve salaries. I don't know how the money they come out, but I think when somebody gets a good salary, then go sleep and able to focus on this work here. I'm here feeling very comfortable. I know the 31st. I know what's going to my account. I don't need for the day. It's pre-programmed. Everybody gets paid. You this, you just take, and I know it's the left day. It'll give me peace of mind. I can sit down. That's why I can write papers. That's why I can publish books. But if somebody there on the daily grind, it's very difficult. Establish long-term MOUs with established training partner institutions. Consistent data monitoring, assessment, and reporting. I said that before. Public health, we don't tell empty stories. We show evidence. That's it from me.
Well done.